And share my screen. Okay. Cool. Can everyone see that? I don't know, Lizzie, can you see that? Yeah. Okay, perfect. So just a bit about Thursday 15. So Thursday 15 is, I'm sure you'll know if you've been to a session of ours before, but it's a teaching series run by F1 and F2 doctors, mostly based in the Northwest. And how it works is it's 15 multiple choice questions, which we'll do in time conditions, so in silence. You'll get a minute per question. We'll then go through the answers, have a bit of teaching, that sort of thing. So it's dermatology today, and what I found most helpful when I had dermatology teaching was pictures and revision slides. So that's sort of what I've tried to go for. If something doesn't make sense, you can always go back over it, as I said. Yeah, I think we should just get started. So if you want to grab a bit of paper and a pen, so you're ready to write your answers down, you'll get a minute per question. Every week you get questions asking if we're sending the slides out and recordings, and yes, we do at the end of the session. So if you stick around and fill in the feedback form at the end, you'll get the slides and recordings sent to you. So hope that clears up as well. Lovely. Okay, so pens and paper at the ready, and I'll time you guys and let you know we're moving on. Okay, let's get my clock up. Right. Ooh, dermatology, obviously. Right. Question 1, let's go. Question 2. Question 3. Question 4. Question 5. Question 6. Question 7. Question 8. Question 9. Question 10. Question 11. Question 12. Question 13. Question 14. Last question, 15. Right, time's up. Okay, hopefully you guys found that okay. We'll go through the answers now, and if you've got any questions at all, pop it in the chat, and Lizzie will answer it or we can discuss it. Cool. So, question 1, I'll put a poll up. Let's see what you guys thought. If you're feeling brave. Cool, so the most popular answer is C. The answer to this is actually B. So let's just talk through it a little bit. So this is a man that has a red rash, which started on his chest, it's spread really rapidly and he's unwell. He's got fever, flu, aching muscles, and the doctor's recently changed one of his medications. On examination, he's got an intensely red rash, which is oozing, his lips are very red. His medication history includes carbamazepine. Does anyone fancy popping in the chat what they think this man has? Any ideas? You're feeling brave? SJS, perfect, exactly right. This man has Stevens-Johnson syndrome. So this is a condition often caused by a change in medications such as antibiotics, or here an anti-epileptic drug, which causes a rash, which is like sloughing of the skin. Your skin starts peeling off. So let's talk about it. It's a severe skin reaction to medications, and it's often really brutal. This is a picture of what it looks like. By the way, most of the images I'm using here from DermNet.nz. I'm not sure if you guys come across this website, but it's so good for dermatology revision. So I definitely recommend you check that one out. And it's separated into TENS, so toxic epidermal necrolysis syndrome and Stevens-Johnson syndrome. And the only difference is that TENS covers over 30% of the skin and SJS covers less than 10%. There's like a 20% overlap, but for the purpose of your examinations, I wouldn't worry about it. And the management of this condition is, first of all, you stop the drug that you think is causing the symptoms. So I've just got a little list there of medications that I found that can cause it. And there might be other ones that you guys have heard of as well. But I think it's good to remember anti-epileptics and antibiotics particularly, so that can sort of point you towards that diagnosis when you're answering questions. And the management for this is best supportive care. So this involves admission to ITU, or the burns unit, somewhere where they've got experience dealing with people who are really unwell and skin conditions. So this sort of patient will be losing a lot of fluid through their skin, and it's the third space. So you need to rehydrate them, is the first one, so fluids. They need pain relief because it's going to be really painful, and also temperature regulation because they're going to be losing a lot of heat through these skin wounds. So hopefully that makes sense. And that gives you guys a better idea of why that's the answer to that question. If there's anything you're still unsure about, just pop in the chat. Okay, question 2. Let's get the poll up. Okay, what do we think? Okay, what did you guys go for? You guys went for C, which is the right answer. Great. So this is a boy that has golden crested lesions around his mouth. He's in nursery, and some of his other classmates had this same issue. His mum's tried using hydrogen peroxide, which hasn't worked. So does anyone know what this boy has? If you want to pop it in the chat, if you're feeling brave. Any ideas? Impetigo, yeah, awesome. So The management of impetigo is just one that's worth learning. So hydrogen peroxide is the first line. So answer A was hydrogen peroxide for another week. This boy's already had it for the last week. It's not improving. So it's probably not worth trying the same thing again. And that's often not the answer I find in multiple choice questions. They often want you to do something different. Oral flucloxacillin would be indicating impetigo if it's not controlled by topical therapies or if the child's particularly unwell. We don't have any evidence here that the child's unwell. Topical fusidic acid is the right answer. Fusidic acid is an antibiotic and it's applied topically. And then hydrocortisone is a steroid and ketoconazole is an antifungal, neither of which are indicated in this because it's an infection. So just a bit about impetigo. So on the right hand side, this is what it looks like. I think if you see in an exam question golden crusting, that's really trying to lead you to impetigo because that's very sort of like textbook description of it. It's caused by Staph aureus or strep pyogenes. Those are two of the main infection causing bacteria in the skin, so they're good to think about. And the management of this, so you keep the child off from school for 48 hours after starting treatment or until the lesions are crusted over. And that's worth remembering. It's a bit more pediatrics than dermatology, but there's a few conditions that kids have that they have to be excluded from school for. So it's worth just sort of getting a little list in your head as you're going through your revision. And then we spoke a bit about the management. So you start by managing with hydrogen peroxide, which is an antiseptic, in the hope that it'll settle down. And then you can move on to a topical antibiotic. And if that isn't working, or you've got extensive impetigo, then oral antibiotics is the way to go. Right. Next one. Just saw a question in the chat. Do you only use oral flucloxacillin if there's systemic symptoms? So you'd use oral flucloxacillin if the child is systemically unwell or if your topical treatments aren't working. So topical is best to go for first because it's a bit less harsh. So if you can solve it with that problem, it's better, but sometimes you will need oral antibiotics, but trying topical first is the way to do it. Hope that makes sense. Question 3. Let's see what you guys thought. Let's get the poll. Sorry, it takes me so long to do polls. There we go. Okay, so we've got a bit of a split. So most popular answers were A and C. So the answer here is actually C. So let's talk about it. This is a woman who has multiple plaque-like rashes. This rash has been present for years. She's always had it, but it clears up when she goes to Spain. It's bad in winter and her mum has a similar issue. It's itchy. If someone wants to pop in the chat what you think is going on here, what condition does this girl have, all these women? Anyone feeling brave? Psoriasis. Yes, lovely. This person has psoriasis. So the treatment of psoriasis is potent topical steroids and vitamin D. So, but you need to apply the steroids at one time of the day and vitamin D at another time of the day. So this is quite important for exams. These two treatments are not applied at the same time. So you can do steroid in the morning and vitamin D in the evening, or vitamin D in the morning and steroid in the evening, but they need to be separate. A few of you thought 8 weeks as well. The way it's actually managed is you do it for 4 weeks and then you have a review, and then if you need to, you can prolong it to 8 weeks, but the first step is to trial a 4-week course. Okay. So psoriasis, this is just a few pictures of psoriasis. As you can see, it's sort of plaque-like, it's scaly, it can be found all over the body. The most common place is sort of on the extensor surfaces of the knees and the elbows, or sometimes on the trunk, but it can be anywhere. It is genetic as well. It's associated with psoriatic arthritis and IBD, and you can have psoriatic nails as well, which I've left a picture down there of, so you can sort of see there's like some lines and some pigmentation on the nails. So that's something to look for in examination of a patient's psoriasis. I've just put a bit what it's aggravated by: infection, smoking, different medications, and it's improved by exposure to the sun. So a rash that improves upon going on holiday is in the question. Think about psoriasis. And it's managed with emollients, steroids, vitamin D, and then you can use phototherapy as well. So that's sort of a bit like going on holiday, but in the same country. So you can use phototherapy as like an adjunct to your treatment. If you've got psoriatic arthritis, methotrexate is quite good. And sorry, that should say biologics. I spelled that wrong, but biologics can also be used, but that's more of a further down the line. That's a systemic treatment. So often the pattern with skin things is try it topically, then systemically. So biology is sort of like a further down the line. And I've just taken a little bit out of the NICE guidance, sorry. So it says there, potent corticosteroid and vitamin D analog, once daily applied separately. So one in the morning, one in the evening, like we said, for up to 4 weeks. The guidelines then go on to say you can apply potent steroids for up to 8 weeks, but importantly, you need to have a review after the 4 weeks to see if it's been working, because if it hasn't been working at all, you then change treatments. But if it is sort of working but needs a bit longer, then you can go for up to 8 weeks. Another thing to mention is that you can only take potent steroids for so long, and that's 8 weeks. So if someone's been having potent steroids for 8 weeks, they need to have a 4-week break. And that's because potent steroids can be quite damaging to the skin themselves. When you take this 4 weeks, you can keep putting the vitamin D on though. And the next option after using steroids, if the steroids aren't working, you can just do vitamin D twice a day. I think there's probably not much more you need to learn for psoriasis treatment. I doubt they'd test you past second or third line. I think it'd be quite harsh if they did. So I just remember steroids and vitamin D. If that's not working, you can have vitamin D twice. Hope that makes sense. Cool. Next question. Pop a poll up. Let's see what you guys thought. So a lot of you guys thought B. The correct answer is actually C. And the reason I put this question in is it's because it's one that I was fooled by when I was a medical student as well. So if someone just wants to pop in the chat what they think's going on. Yeah, cellulitis, perfect. So this patient is in hospital. They've got a swollen lower leg, which is hot to touch and painful. She's been feverish, and you can see in her observation she's tacky and she's got a low-grade fever. So this person has cellulitis, a really common condition in people who are in hospital, and it's actually majority caused by strep pyogenes. I think it's really easy to think that it's Staph aureus because that's the main skin-causing bacteria that you hear of, but it isn't. It's strep pyogenes. Yeah, so just reasons why it's not DVT. So obviously DVT is a really important thing to rule out in patients who have a red swollen lower limb, but she's been feeling feverish and she's got a low-grade temperature. That sort of leads you to thinking it's an infection. Staph aureus, we've talked about, can cause cellulitis, but it's not the most likely cause. Strep pyogenes cause it in the most instance. Fluid overload, again, can cause swollen calves, but it tends to be both calves bilaterally rather than just one. And atopic dermatitis is just another name for eczema, but this patient's behaving like they have an infection, so cellulitis is the right answer. So cellulitis, so that's a pic of what cellulitis looks like. Often in hospital, it's really good to draw a line around where the cellulitis is. So when you're treating a person, you can tell if the erythema is extending or whether it's regressing. You want to see that your treatment's working. So just clinically, if you're on the ward, make sure you're drawing lines around the cellulitis is. It presents with redness, pain and swelling, and it's hot to touch. Risk factors as well: venous insufficiency, being old, diabetic, immunosuppressed, or if you have any sort of cuts or grays in your skin that bacteria can get into. Then management is antibiotics, and we already spoke about why it's important to draw around the redness. Just to make sure that you're spotting whether the treatment's working or whether you need to change treatments, things like that. Cool. That makes sense. Right. Next question. Sorry, so slow at this, right? Okay. What do you think? Okay, so a lot of you guys went for B, and B is the right answer. So well done. So anyone want to pop in the chat what you think is going on here? What condition does this lady have? Yeah, limited cutaneous sclerosis, exactly. So the way you can tell this is a lady who has difficult swallowing, and the skin on her fingers is tightened. She's got a red rash around her lips. So this is sort of synonymous with CREST syndrome, which is what limited cutaneous sclerosis used to be called. We'll go on to talk about a little bit of how you can identify what CREST syndrome is, but just going through the other answers. Rheumatoid factor, that's present in a lot of rheumatoid conditions, sort of rheumatoid arthritis. Anti-centromere antibodies is the right answer. That's present in limited cutaneous sclerosis. Anti-Smith antibodies, they're often present in lupus disease. And then anchor antibodies are associated with vasculitis. But you guys got the right answer, so well done. So CREST syndrome, or limited systemic sclerosis, is an anti-centromere positive hardening and sclerosis of the skin. So it can be, systemic sclerosis can be classified into limited and diffuse. So that sort of does what it says on the tin. So limited is more peripheral and diffuse is widespread, involves the organs. Limited used to be called CREST syndrome, and it's called CREST syndrome just because of that little diagram on the side. So you get calcinosis, Raynaud's, esophageal dysmotility, which is why that lady had difficulty swallowing, sclerodactyly, which is a tightening of the fingers that lady had, and telangiectasia, which if we go back, this lady has telangiectasia on her lips, and if you can see that picture closely, so that's one to look out for. And then diffuse involves the kidneys, the lungs and the heart, and can be quite damaging. And that's also often ANA positive, but it tends to also be anti-SCL70 positive. With the autoantibodies, there is sometimes overlap. So not all patients will have this antibody, and some will have the antibody who don't have this disease, but this is where the antibody is seen most commonly. You also have overlap syndrome, which is where you have a bit of both. Just if you see someone in the question who looks like they have CREST syndrome, but has sort of other involvement as well of the organs, and they might have overlap syndrome. Okay. Hopefully, I'm just checking the chat as well. You're not asking questions on Lizzie's answering them very quickly, so thank you very much, Lizzie. Hopefully everyone understands that. With antibodies, it's worth learning just a few of which match up with which condition, because you sometimes get asked it, but they are quite hard to remember. So if you struggle remembering them, try not to worry about it. Okay, question 6. Just put the poll up. So a lot of you went for A, B, E. So the answer here is actually E. Anyone want to pop in the chat what they think is going on here? Eczema hepaticum. Yeah, brilliant. So this is a dermatological emergency, which presents with itchy, painful blisters. And these blisters can sometimes be filled with pus, bleeding, and can be associated with cold sores. We'll talk a bit about why this is relevant in a minute. It's associated with eczema as well, and it's managed with acyclovir. This is because it's caused by the herpes virus, which is why you sometimes have cold sores, because this can sort of be where it spreads from. A lot of you put acyclovir and flucloxacillin. This is a viral condition. You might have been a bit confused by the pus and the blisters, but this condition isn't treated with antibiotics, at least initially. The management for this is IV acyclovir, and this is often why people need admitting to hospital to be managed with IV antibiotics, because they often present really unwell. If at some point down the line you think it's become infected, you can then use antibiotics, but the first line treatment for this is just acyclovir. Cool. So it's often caused by herpes virus 1 or 2, which is why it's associated with cold sores, eczema we spoke about. The symptoms are the progressive painful rash with the blisters and the bleeding, fever, may have secondary bacterial infection, and when in hospital you can treat this with antibiotics, but initially the management is just acyclovir. If it's near or around the eyes, you can get an ophthalmology review. This is because you can get it in the eyes, which can lead to blindness. This patient just had it on his chin and his cheeks though. So in this case, you don't need an ophthalmology review. Is the reason it's eczema hepaticum because it's a past medical history of eczema? Yeah, that's one of the reasons. It is associated with eczema, but sort of the description of the rash and the picture of those sort of vesicles on the face is mostly the reason why it's eczema hepaticum. I think also because he's presenting quite unwell as well. Yeah. Cool. Question 7. Let's get a poll up. Okay, so a lot of you picked C. The answer is actually B. If you're not getting these questions right, by the way, don't worry. I've designed these questions to try and be really difficult, just so there's actually point in you being here and you're learning things. So don't be disheartened at all, and we'll go through all the answers. So this is a lady who has a red rash that's been present for the last 2 weeks. Oh, I don't know why that's only changed 4 months. It's still 2 weeks. It's mildly itchy and she's considered spread. Does anyone know what's going on here? Pop it in the chat. Yeah, that's great. Pityriasis rosea. This is a condition that's often caused by a viral infection. Herpes 6 or 7 are the viruses I've found that cause it the most. And it's a painless scaly rash which starts with a herald patch. So I've done a little circle around the herald patch, so hopefully you can see that. So what it means by that is a herald patch is the big sort of spot that appears first, and then you have little rashes dotted around it. It often has a fir tree appearance, and the way I sort of remember this is because most cases happen in winter, so it happens in winter and it has a Christmas tree pattern. That fits quite nicely, and it can change the skin pigmentation. Importantly, this condition is actually self-limiting. It doesn't require any treatment at all, and it lasts about 6 to 12 weeks. So if you see someone presenting with this and they're worried about it, they don't need any management because it'll go away by itself. Yeah. And I think some of you put, what did some of you put? Ketoconazole, that's sort of a different rash you might be thinking of. This maybe pityriasis versicolor, I think is caused by a fungus. This one's caused by a virus and doesn't need any antifungals. So this is the Christmas tree rash. Yes, this can present in a Christmas tree pattern. This picture, I chose this picture mainly because it has quite a good herald patch, you can see. It doesn't, granted, it just doesn't particularly look like a fir tree there. But if in exam questions they say the rash looks like a Christmas tree or looks like a fir tree, this is what they're aiming to get you at. Is why I put that in there, because it's quite textbook for this. Cool. Next question. Sorry, I'm really slow getting these polls up. Let's see what you thought. Cool, so most of you went for D, which is the right answer. Can anyone pop in the chat what you think is going on here? What's this condition? Melanoma, exactly, perfect. So the way that this leads you to melanoma, sorry that picture's not very good quality, but it's a man who's got a new mole. It appears suddenly and grown in size. The growing in size is key. He was raised in Australia, and it's a regular lesion with different shades of brown. So just go through what the other answers are. Gleason score is actually a marker of prostate cancer. Child-Pugh is used for cirrhotic liver disease, I think. Clark level is actually melanomas, but it's to do with the invasion rather than the thickness, and the thickness is the prognostic marker. And then Hutchinson's sign is a sign of subungual melanoma. So when the melanoma gets into your nail beds and you get sort of a brownness called Hutchinson's sign, but it's not a prognostic indicator. Cool, just talk about melanoma a little bit. So you can have different types of melanoma. They're cancer of the melanocytes, which is the skin cells that pick up sun. And you can have it in situ, which means it's a cancer that's growing on the skin. You can have it as invasive, which is when it goes below the epidermis, sort of into the dermis, when it's invading into the dermis. Or malignant, which is, I'm sure you know, when it spreads to the lymph nodes, to the blood, to anywhere else that is in the skin. Risk factors, sun damage. So this man grew up in Australia, I think, so that's a risk factor. Type 1 skin, which is sort of when you're very pale, you often have fair hair. And the features, so I always remember it as A to F. So I put on the side A to F, and A to F is how you think about whether something is cancerous or not. So these are all signs that something is going to be cancerous. So if the mole is asymmetric, so if it's not uniform, if it's not like circular, borders, so if the borders are like jaggedy rather than smooth, that's more likely to be a cancer. Color, so if it has different colors inside it. So this guy's melanoma had different shades of brown, so that's an indicator that something's melanoma rather than just a simple mole. Diameter, so if it's larger, it can often be a melanoma rather than a mole. Evolving, that means growing quickly, so if it's evolving quickly, that's a sign of cancer, because cancer are quite fast growing. And then funny looking mole, that's a bit of an odd one, but I think that's actually the best way to identify something might be cancerous, if it just looks a bit weird. I think clinically, I'm not sure if you guys find this, but in GP practices, a lot of GPs just refer anything they think looks a bit funny to a dermatologist. This is actually maybe the most relevant one for practice. The risk of metastasizing increases with the thickness, which is why the Breslow thickness is the prognostic indicator, because it's the higher risk of metastasizing, which is the prognostic indicator, because if it metastasizes, it's more likely to be fatal. And then diagnosis is clinical, so you can diagnose it clinically if you're a good dermatologist, or biopsy is also used. And then the management is just excise it. So you can do that with just like a knife, or with cryotherapy or cartilage, or that sort of thing. Cool, well done. Next question. Let's get the poll up. Let's see what you guys put. So you went for A and B, a bit of a split. So the answer is A. Have I done that right? Yeah, they did that. So the answer is A. So can anyone pop in the chat what they think this man has? Any ideas? Lichen planus. Yeah, perfect. So it's an itchy rash. It's along the side of a nose scratch. He's got some on the inside of his cheeks. Purple papules with white lines, and a painless white rash on the inside of his cheek. So the white lines that are on the purple papules are actually called Wickham striae. Kovner phenomenon is described in this paragraph, and it's actually also present on the rash. So Kovner phenomenon is where the rash occurs along the side of an old scratch. So just be careful what the question's asking you, because Kovner's phenomenon was described, but it's actually asking you what's the name of the white lines, which is the striae rather than the phenomenon. Herald patch we spoke about a bit, that's the pityriasis first patch that appears. Xerotica obliterans is actually lichen sclerosis, which appears on the penis. And then Hutchinson sign, again, we spoke about the subungual melanoma. So I thought it'd be helpful just to do a bit of a differentiation between lichen planus and lichen sclerosis. I get them quite confused when I was a medical student, I think because they both started lichen and I never really knew what either of them were. But lichen planus, I remember it's all P's. So it's purple pruritic, which means itchy, planar and papules. So if you see any of those words in the exam question, think about lichen planus. It can occur on the mouth, so that's sort of the white patches that were described in the question. And then the Wickham striae are the white sort of lines and the patches in the mouth as well, which occur with lichen planus. Kovner phenomenon we talked about, and can everyone see in the picture the sort of line of lichen planus? That to me looks like a scratch that the planus is then growing along. And then the management is with topical steroids. Lichen sclerosis is actually quite different. It's white rather than purple, and it's often present in the genitalia rather than the mouth. So I think those are two quite good ways to differentiate them. One's purple, one's white, one's the mouth, one's the genitalia. So just try to remember that if you're getting confused. But again, actually clinically, I'm not even sure it matters that much because I manage the same. But just for the sake of your exams, and steroids is the way to go as well. Great. Question 10. Let's get a poll up. Oh, sorry, hang on. There we go. Polls. I seem to have lost the poll function. Sorry about that. Any ideas? Pop it in the chat what you think is going on. Oh, hang on. Yeah, I've got it.
I've just relaunched it. I don't know if that's worked.
Oh yeah, cheers, Lizzie. Cool. So you guys went for answer A, which is the right answer. Well done. So in the chat, anyone got any ideas what's going on here? What's this girl got? Anyone feeling brave? Yeah, eczema. Nice one, well done. So this girl has eczema. It's an itchy rash, really, really itchy. She's had a similar rash on the flexor surfaces of her arms. She's stressed at the minute, cracking, bleeding and scratch marks. She's also got a past medical history of asthma. So I'm sure you guys know this already, but there's an association between asthma, hay fever and eczema. It's called atopy. So if you see someone with a past medical history of asthma or eczema or whatever, think about the other two. Might not be the answer, but it's just worth thinking about. And the appropriate treatment for this is steroids. So let's go through the answer. So moderate topical steroid is the right answer, and this is because it's on the face. So you don't tend to use potent steroids on the face, and use moderate steroids instead, which is why it's the right answer. Chlorphenamine is an antihistamine. Antihistamines can be used for itch. They're used sort of as an adjunct though, rather than a treatment. So it wouldn't be the right answer here. Also, chlorphenamine is a sedating antihistamine, and she's actually said she's sleeping well, so it wouldn't be appropriate to use a sedating antihistamine with her. Topical tacrolimus can be used preventatively and to treat to prevent flares, but it's not used first line as a treatment. And then the Fluclox is obviously an antibiotic. There's no real evidence she's got an infection with her eczema here. Yeah, so Fluclox isn't the right answer. So when you're thinking about how to manage eczema, you need to decide. So I've just taken this from the NICE website, by the way, NICE guidelines. Think about whether it's mild, moderate or severe. So I've just popped in, or infected even. So I've just popped in here how you might be able to tell. I think clinically there's probably quite a lot of overlap. And for the sake of your exams, I doubt they'll ask you to classify eczema, but just sort of go think about it like logically. If it's just dry skin, a bit of itching, it's probably mild. But if it's dry, really itchy, bleeding, cracking, it sounds really nasty, it's probably severe eczema. So this is where the right answer came from. So this is the severe eczema page. If the skin's inflamed, which this is, it's itchy, it's cracking, it's bleeding, prescribe a potent corticosteroid, but for delicate areas such as the face, use a moderate potency. So hopefully you can understand why that's the right answer there. So a bit about eczema. So I just thought we'd do the management of eczema because I'm sure I don't want to be preaching to the choir. I'm sure you all know what eczema is. It's really common. It's often in the flexural surfaces. So the picture here is someone's elbows where you might often see it. And the way you management is with regular emollients. So loads and loads of like emollient creams in the bath, out of the bath. You can use them sort of all day if they wanted to. And then you use steroids. So you tend to step up steroids if the eczema isn't too bad. So you can go mild, moderate and severe. But then in exam questions, if someone's got severe eczema, just sort of use your common sense, like is a mild steroid going to be able to treat it? They might need a moderate potency steroid or a severe or a very potent steroid. And then as with most conditions, if the topical treatments aren't working, you can use a systemic one. And the systemic treatment you can use here is oral steroids. And there are also adjuncts that we talked about a little bit. So if someone's really, really itchy, you can use a non-staging antihistamine, something like loratadine. If the itch is affecting sleep, it's quite good to use a sedating antihistamine like chlorphenamine, because then you get this sort of two-pronged approach of helping the itch and helping them sleep, which is really good. And if it looks to be infected, so there's a lot of like pus coming from it, or they've got a raised temperature, or they're feverish or anything like that, and you can use antibiotics. And the antibiotic you tend to use is flucloxacillin because it's quite good for skin. And then you can also prevent eczema. If someone has really severe flares, you can use topical steroids twice weekly or topical tacrolimus. You don't really want to use steroids more than twice weekly because you can get a steroid withdrawal, which is when the skin becomes quite poorly just from using a lot of steroids. And then if you stop using steroids, you can get quite bad skin symptoms, you can get quite a bad rash, and you can be quite unwell in yourself as well. Importantly as well, if eczema has sort of struggled to being managed in the community, you can always refer into dermatology. Dermatologists have access to more potent drugs than GPs. So just an exam question, if there's been a lot of treatments trials in general practice, often referring them to a dermatologist can be the right answer for that. But not in this case, because she's not even tried treatment yet. That makes sense. Cool. Question 11. Just put a poll up. So you guys thought? Cool. So a lot of you went for E. So E is the correct answer. So well done, guys. Can anyone tell me what they think is going on here? We've got BCC, yeah. So this is a skin cancer. So looking at it, it's a funny looking mole. We already talked about F for funny looking mole. We know that's an indicator this might be a cancer. He's had it for the last 6 months and it's growing rapidly. So E for evolving. Itchy and painful. He's got a painless lump in his neck. He used to work as a gardener in France. So he's probably had quite a lot of sun exposure. He's got an irregularly shaped crusted red lesion with some visible vessels as well. So the painless lump in his neck is just sort of getting the fact that this cancer has metastasized. So skin cancers tend to metastasize to the lymph nodes as well. This is why he's got a lump in his neck. Just thinking about the other answers, so this condition is caused by the p53 tumor suppressor gene. This is true, but this is not the most appropriate advice to give to the patient. He probably won't care. Well, he might, but it's more important to talk about his future investigations and management than it is the sort of genetic cause of it. This is unlikely to metastasize and will not require treatment. This is untrue. The question is sort of getting out that it's already metastasizing and it will likely require treatment. Nicotinamide can treat this lesion. This isn't true. So nicotinamide can prevent skin cancers. If you have a patient who's had a lot of BCCs or a lot of SCCs, you can treat them with nicotinamide to try and prevent them from getting more, but it cannot treat their existing lesions. And then number D, sun exposure can help resolve this lesion. This isn't true. Sun exposure can cause this lesion. So E, he may require a CT scan. This is true. If you're expecting that skin cancers metastasize, you need to get a scan. And CT scans can be good at picking up metastases from skin cancers. Question in the chat, how do you distinguish between a BCC and an SCC? Oh, it's like you read my mind, right? So here we've got a BCC and an SCC. So the first thing to say is clinically, it doesn't make that much of a difference. They're managed in the same way. They need a referral to dermatology and the dermatologist needs to excise it. And sometimes you can only tell if it's a BCC or an SCC when it's been biopsied and actually looked at under a microscope. But sort of things that I think tell the difference between them. So BCCs are typically described as having pearled edges. So you can, I'm not sure you can see the picture on the left. It looks sort of pearled and raised and a bit like the edges are quite smooth, if you can see that. And they often have telangiectasia in as well. And they tend to be more circular. A lot of textbooks say BCCs are more common on the face and hands as well. So maybe you can go by that. But I think if you think of like the pearled rolled edges, that's what they tend to look like. I always think the SCCs, which is on the right, just look like a really nasty graze. it sort of starts as a lesion, it becomes like really bleeding, crusty. But clinically, a BCC can have bleeding, crusting as well. So I'd just say an SCC often looks worse in my eyes. I'm not sure, Lizzie, if you have a better way of telling between them. But
yeah, I think generally the pearled royal edge just always comes up in questions, and the telangiectasia. I think the key thing is that SCCs are really based on the kind of keratotic middle, so they just generally look really like rough, and generally if you feel over them they feel really rough as well, and that puts you more towards like a SCC.
Yeah, thanks. Yeah, I think I've always thought that SCCs look worse. They just look quite sore and a bit nasty, but for management wise they manage the same. You need to refer them to a dermatologist and get it excised. Yeah, hope that answers your question. Cool. Question 12. Just launch a poll. Cool. So a lot of you guys put D, most common answer, and the answer is D. So well done. Anyone fancy popping in the chat what you think this is? Bullous pemphigoid. Yeah, perfect. Well done. So this is a rash with fluid-filled blisters. It's present in the skin flexures and it's itchy, but it's otherwise not bothering hair. So this is a negative question. So which statement is not true? So I'm sorry for putting these in. They're a bit harder to wrap your head around, but exams do use these, so I thought they were quite good to practice. So the other statements are true. So there can be a non-specific rash before the blisters appear. All that means is you can have a bit of redness, a bit of scaling, and then the blisters which sort of tell you it's pemphigoid. It's more common in the elderly. It can be diagnosed with skin biopsy and immunofluorescence. A lot of skin conditions are diagnosed with biopsy, just because you can then look at it under the microscope and find out exactly what it is. So that's often the right answer for skin stuff. It is managed with steroids, again, topical first and then oral. And it often presents with blisters in the mouth. So this is wrong. So it often presents with blisters in the mouth is a sign of pemphigus vulgaris, which are two often confused conditions. But vulgaris is the blisters in the mouth, but pemphigoid isn't. So moving on. So bullous pemphigoid is an autoimmune chronic blistering disease, and all that sort of means is you see lots and lots of blisters. Autoimmune, I think, generally just means that you don't really know why people get it. Some people are just more susceptible to it. Risk factors, immunotherapy, you can get it with psoriasis as well, and if you're a bit elderly. We spoke about it doesn't tend to involve mucous membrane, which is why it's different to pemphigus vulgaris. So I think the two can be confused quite easily, but if someone has it in sort of the mouth, the genitalia, that's pemphigus vulgaris, whereas pemphigoid doesn't involve mucous membranes. And then management, topical steroids. You can then move on to oral steroids, so the potent topical ones aren't controlling it. Great. Let's get another poll up. Okay, let's see what you guys thought. So a lot of you went for E, which is the correct answer, so well done. So this is a medication question, so sorry for any of you that have just done the PSA. Hopefully you don't find this question too triggering. I'm sure you all did well anyway. This is a girl who's got acne. She's gone to the dermatologist. Dermatologist wants to start on isotretinoin. So a really important feature of isotretinoin is it can cause fetus abnormalities. So they do pregnancy tests on people before they start isotretinoin, and the person starting this medication has to commit to using contraception that's reliable. So this often means getting a coil or starting the pill, something like that. I think they prefer you to use contraception on top of condoms as well. That's a conversation that dermatologists have. But contraception is really important if you're on this medication. They do a pregnancy test. Just a little bit about acne. So acne can be managed in a lot of different ways. I think what's sort of important to know about it is you go for topical treatments first and then oral treatments. So this I just took from the NICE guidelines. So you can use different topical treatments, including adapalene, benzoyl peroxide, tretinoin, clindamycin, those sort of things. And then you can add antibiotics in as well. So that's just like a little slide to look up if you're revising, if you're wondering what treatments they use. You can only use isotretinoin if you're over 12 and you've got acne that's resistant to treatment. It can't be prescribed in primary care. So anyone whose acne is bad enough for isotretinoin needs referrals to a dermatologist, which sort of makes sense anyway. If you've got really resistant acne, you should be seen by a dermatologist anyway. And we already spoke about the need to take contraception with this. Just reading out something that's been sent into the chat. Someone just sent to me, Lizzie, a useful tip that's been sent in. I learnt bullous pemphivoid, so they avoid the mucosal surfaces such as the mouth. That's a good tip. So bullous pemphivoid, so avoids the mouth. That's a good one. Question 14. Let's get a poll up. So a lot of you went for A. Share results. The correct answer is actually B. So does anyone know what this man has? Yeah, seborrheic keratoses. So seborrheic keratoses are completely harmless. They're sometimes called sunspots. And the way that you can tell us in this question is this is a man who has many moles, and his partner pointed this out to him last week. The fact that his partner pointed it out to him last week sort of tells you that actually it's probably been there for a while. The picture shows it sort of scattered around other moles that look quite similar. He's well himself. It's a little bit itchy, so it's clearly not painful, bleeding, any of those sort of nasty symptoms of skin cancers. He grew up in the UK and works in IT. That's sort of telling you that he's not spent a lot of time in the sun, so he doesn't have that risk factor. So talking about the other treatments, so 2-week wait to dermatology. So that's not appropriate in this patient. This patient doesn't have skin cancer. Biopsy shavings in a GP clinic. Typically GPs don't tend to do biopsy shavings. I think some of them do, but if you're going to take biopsy shavings, you'd probably be referring to dermatology anyway. Flucloxacillin is an antibiotic. This man doesn't have an infection. And then hydrocortisone isn't indicated in this condition either. So seborrheic keratoses, I think some people can confuse them with melanomas. And I think the way to differentiate between them in the question is a history. So a melanoma is fast growing, a bit painful, a bit itchy, looks really funny, looks very different to their other moles. Seborrheic keratoses look like they're stuck on. So I'm not sure you can see in this picture, it sort of looks like, it doesn't really look like it's part of the skin. So a melanoma is a cancer of the melanocytes, which is a skin cell. So it won't really look raised, it'll look like it's part of the skin. This lesion very much looks like someone's just sort of glued it onto the skin, which is how you can tell the difference looking at it. I think also the fact that it's just like a little bit itchy, that's not particularly concerning. And the treatment for them, you don't do anything for them. Often old people have a lot of them. I think they're seen really commonly in GP practices, and you can remove them if they're unsightly or annoying. So you can use like lasers and things like that, but that's not a treatment that's recommended. It's just if they're like catchy on clothes or they're really big. Yeah, hope that makes sense. If anyone has any questions about how to differentiate between melanomas and seborrheic keratoses, just pop it in the chat. But I think about how they're being described and sort of the symptoms the patient has with them as well. Okay, last question. God, we've seen through. Hope this has been an okay pace. Yeah. Let's see what you guys thought. So a lot of you went for B, which is the right answer. So can anyone pop in the chat what they think's going on? Yes, this is acne rosacea. So the way you can tell this is it's a red rash that's covering his cheeks, nose and chin. So the typical distribution of rosacea is sort of across the bridge of your nose like that and around the chin as well. He feels like he looks flushed. He's got papules, pustules and telangiectasia. The nose appears dimpled and the skin is thicker here. Sort of for a bonus mark, does anyone know what the thickening of the skin around the nose is called? Does that have interest? Rhinophyma, yeah, perfect. So that's very typical of rosacea. If an exam question is talking about the thickening of the nose, and in the picture you can see it's very dimpled, that is rhinophyma and it's associated with rosacea. So just talking about other options for this, so reassurance. I mean, you can reassure this patient. It's not a particularly harmful condition, but there is actually a treatment for it, and one that should be used, which is ivermectin. Referral to dermatology is indicated because of the rhinophyma. So that sort of means that the condition is quite extensive and worth seeing by a professional a specialist rather than general practice. Erythromycin, you can use antibiotics for rosacea, but not as a first-line treatment. Fusidic acid isn't indicated. That's treatment for impetigo, as we spoke about before. And then betamethasone and referral to dermatology. Steroids is not the answer for this. Cool, so just talking about acne rosacea. So it's a chronic inflammatory skin disease. As we spoke about before, it's got the typical distribution of the cheeks, the nose and the chin. You get flushing, you get telangiectasia. So if there's sort of a widespread redness with telangiectasia, it's rosacea, it's quite typical. And yeah, that's right, that means sort of infection around the eyelids, which sort of makes sense. It's around the cheeks and spread up into the eyelids. And rhinophyma, which is that redness and dimpling of the nose that we spoke about before. You can manage it in different ways. So if it's just the erythema that's bothering the patient, you can give brimonidine, which I think is an alpha antagonist that just reduces the redness of the skin, but it doesn't actually treat the condition. You can treat the papules and pustules that this man has with topical ivermectin, and second line is metronidazole or azelaic acid. And then if someone has severe rosacea, you can use topical ivermectin, and also oral doxycycline is the first line antibiotic for this. Cool, so that is the end. I think Lizzie's been keeping an eye on the chat, but if there's any questions you have, just pop it in the Q&A. We'll both be around for a little bit. This is the feedback form, so please fill in the link. Lizzie, would you mind just putting the link into the chat again, just so people can fill it in that way if they would prefer. And when you fill in the link, you can get to the slides and recordings, which I'll send out. I won't send out this weekend because I'm going on holiday tomorrow, but I'll send it out early next week. Hopefully that's soon enough. Question in the chat: can I relate sun exposure to the melanoma but not the seborrheic keratosis? Yeah, so if in the STEM it's saying they've lived in Australia, they're working outside, there's a lot of sun exposure, this is more likely to be a skin cancer. So yeah, you definitely can. I think it is difficult clinically to tell the difference between melanomas and seborrheic keratoses, and in reality some do get referred to dermatology, but for the purpose of an exam question, really think about that A to F and description of skin cancers to try and help you work out whether it's cancer or whether it's a keratosis. Have a good holiday. Thank you very much. Incidentally, if anyone has any recommendations for Copenhagen, please pop them in the chat. Lizzie, I think you've probably answered loads of them. Lizzie, I think, is a bit of a dermatology whiz, so I'm very pleased to have had her here. Oh, the QR code sends the form for a gastro talk. Oh, it shouldn't. Are we sure? Let me have a look. No, that QR code does go to dermatology one, I think. Is everyone else getting the link to dermatology one rather than a gastro one? I've just tried it myself. I think it does go to dermatology. Lizzie, would you mind just checking it for me if you scan that QR code to make sure it's going to the dermatology form? That'd be great.
Yeah, it looks like dermatology for me as well.
Okay, perfect. I just want to say gastro. Oh, sorry. It must have just been copied over wrong. It's all about dermatology. So if it's saying about gastro, don't worry about it. Sorry. Just pretend it says dermatology. If anyone's got any questions before you go, just pop it in the chat or in the Q&A and we can answer them. I can't see any more questions or anything else, so I think we'll end it there. Thank you everyone so much for attending. Join us next Thursday for another session, which promises to be just as good or even better. And hopefully you found it helpful. As I said, I'll be sending out the slides and recordings next week, so keep an eye out for that in your inbox if you filled in the feedback form. Okay, thank you everyone for coming and have a good rest of your evening.